So yeah, based on the show of hands earlier, I know that many of you have heard me speak about the connected care strategy, so bear with me as I go through it again. For those that are hearing this for the first time, if I'm going through it very quickly, so if you have questions about the presentation or about the strategy, don't hesitate to come grab me at lunchtime and ask, or ask any of our team members. As I mentioned earlier, this is the, what we're calling the next phase of work related to the ED Waits and Patient Flow Initiative. And just want to remind people that of the HOSHN target, which we all know we're working towards, which is a 60% reduction in ED wait times by March of 2019. So that is the North Star that we are sort of moving towards as an initiative. And when we say 60% reduction, we're talking about three key metrics in the emergency department: the time for patients to see a physician when they come to the emergency department, the time waiting for an inpatient bed once they are admitted to hospital, and their entire length of stay from the time of registration to the time that they leave the department, whether that's for admitted or non-admitted patients. And so for us, the ED Waits and Patient Flow Initiative, as you remember, we launched on the heels of the SAS Surgical Initiative, which we saw, I think, it was a really good example when you align efforts as a system towards a single goal, what you can achieve. And we took our wait times from some of the highest in the country down to some of the lowest in the country. And as we launched, though, the reality was that the economy took a bit of a turn at that time too. So we didn't realize some of the investments that we were hoping for. And our team often reflects back on that, and we say that for us was a real blessing in disguise. Because had we been given sum of money at that point in time, I honestly think we would have invested inappropriately and in areas that we probably wouldn't have gotten the best benefit. So what that did is that lack of investment, if you will, it provided us the luxury of being able to do a deep dive and understand the problem in Saskatchewan and do a really thorough root cause analysis. It also allowed us to launch some of the foundational activity that is now going to pay dividends as we move forward, and that is the work around moving the interdisciplinary rounds to the bedside and having the conversations with patients and families, starting discharge planning upon admission into hospital, understanding the detail of our alternate level of care population in the province, which I think is critical, because when we launched, we knew we had an ALC problem, but it was anecdotal. Other than those patients that were waiting for long-term care, we really didn't understand the profile of those patients. And thanks to the coordinated efforts of all of you in the system, we now have a common methodology of data capture. We have an electronic database. We are understanding that 30% of our inpatient units that are ALC, what are their needs so that we can start to safely transfer their care into the community. So I think none of that work would have happened had we just started off launching into activity right off the bat. So I really do believe it was a blessing in disguise for us. One of the things, because of a chance meeting between Dr. Bazran and one of our local computer scientists in the province, Dr. Nate Osgood, is we started thinking about how we might utilize health system modeling to help to come up with an evidence-based approach at the solutions for patient flow. So this was, health system modeling has been used nationally and internationally, but we hired a modeler from Singapore, Yuan Tian, who's in the crowd somewhere, Yuan? There she is in the back. And she's done an exceptional job creating health system models for our hospitals in Saskatoon, Regina, and PA. And what that's allowed us to do, as many of you have heard before, is to run what-if scenarios or virtual pilots. So we're able to make some assumptions, and without having to invest in the system, understand what an intervention impact of an intervention might have up and downstream, but specifically on the wait time metrics in the emergency department. So it really allowed us to start thinking it through when and if we do get funding, where we can best utilize that funding. So through the modeling, this is just a few of the things that we modeled. we know that lots of people think that the simple solution to an emergency department wait times is just build urgent care centers. Get rid of the CTAS 4s and 5s, the family practice sensitive conditions out of the ED, problem solved. And so we modeled that, and we've learned from other jurisdictions that have tried strategies that way that it doesn't work. So it has very low impact actually on wait times. So diversion activity, we kind of thought, okay, that's not the right approach. But we did look at what would happen if we were able to successfully move that ALC population out of the hospital and care for them in the community, create more capacity in the hospital. What would happen if we took the concept that was emerging out of the pilot project at Pasqua 4A, the accountable care unit? What would happen if we could actually see some of those results across the entire system? Again, high impact on wait times in the emergency department. What would happen if we could look at this evidence-based package at transitions of care, which I'll talk more about in a minute? And again, it's high impact. And what it all related to was impact on hospital occupancy rates. Once you can drive that length of stay down and drive hospital occupancy rates down, that's when patient flow starts to occur. That's when you get your admitted patient in the emergency department into an appropriate bed to be cared for appropriately, and you get better flow through the emergency department. So your wait times for physician, wait times for bed start to drop. So it was great. This validated what we read in the literature, validated what we had learned from other jurisdictions, but we were able to apply it to our local context, use our data, use our hospital model, and understand the impact that these interventions were going to have. So the high quality care transitions, you've heard lots about this, and this was based on a systematic review done by Burke and his associates in the United States, where they just looked at jurisdictions, programs that have had successful transitions of care based on readmission rates and clinical outcomes. We've reached out to Burke and said, is it okay if we start using this this idea, this bridge, this concept of the bridge? And they said, yeah, run with it. So we've rebranded it to be high quality care transitions. But I do want to acknowledge that this comes off a systematic review by Burke. And in that, they really identified 10 domains that are really important, really critical to safe patient transfers. And again, you can read through them at your own time. I'm sure many of you have seen them and know this very well. So our team started thinking about, okay, well, what are some of the solutions going to be? And we thought, well, we could just simply put together a change management package around high quality care transitions, launch it into the system and say, hey, our work's done here. But that would be simple, but we realized that probably wouldn't be sustainable over the long run, that there was a complex but more difficult but correct answer, and that is really, if we go back to the concept of the bridge, we realized that we needed to strengthen the pillars of the bridge before we could have that sort of successful high quality care transitions occurring across the bridge. And really what that meant was looking at team-based care in hospital, team-based care in community, and ensuring that we've got the right structure, the right processes, and to ensure that those high-quality care transitions can occur. So what do we mean when we start talking about high or team-based care in the community and team-based care? Again, this is not new, as you know. There are many examples of high functioning teams in our healthcare system across the entire care continuum. So I don't want to leave the impression that this isn't occurring. But when we start to think about what we want it is across the entire system, on the community side, it's about teams that understand the communities in which they exist. So it's really looking at the data, looking at the community profile, what's the burden of disease, what's the health utilization, what are the current services that exist in that community. It's load leveling, what are the demands from that patient population to what the services that you're providing. It's more difficult in the community side, but the concept of co-location of team, we know that co-locating is not going to, in and of itself, create a high-functioning team, but it's certainly one of the enablers. So where it's possible, how can we co-locate teams in the community? And having designated physician leadership to the teams and defined boundaries that teams are accountable for, so that there's really clear boundaries where they say this is the patient population that our team is accountable for their outcomes. And the outcomes, you know, we would suggest are both the clinical outcomes and the financial outcomes of the team. On the hospital side, a little more, a little simpler, I suppose, if you will. Some of these concepts that we've taken here are from the accountable care unit, okay, but can be applied to any team setting in a hospital. So these are not just for accountable or for the accountable care units, but what we're talking about on the hospital side is nurse-physician co-leadership on a unit and dedicated unit-based teams. So and you've heard about the concept of the accountable care unit. Right now, our physicians in our hospitals, they see patients on multiple units. Occasionally, they see patients in multiple hospitals. In this model, you have a dedicated physician to a single unit. You have dedicated interprofessional staff where it's possible. And when you have a team that's co-located physically and they're all accountable to the one unit, you can just start to imagine how that culture of teamness starts to evolve. But that's not, like as I said before, co-location isn't in and of itself enough. So it's really around the rigid, structured processes that are in place to ensure how teams are communicating with each other and how they're communicating with patients and families. That's where the magic occurs, I believe. And it's about, you know, and so you've heard the term cyber, SIBR, that's structured interdisciplinary bedside rounds, but so that's the way teams are communicating with patients and families, same time, every day, very scripted, nothing slips through the cracks. The beauty of this model is that when a patient starts to deteriorate on a unit, the teams aren't going across trying to track down the physician. They literally walk down the hall, grab him by the hand and pull him down the hall and say, come see the patient now. And so you know, the mortality rates are dropping on these units. It's safer care. So lots of excitement there. It is really about teams understanding and utilizing their data on the unit though. So we put up ALC data here because we think it's such a critical one. But the patients, if we know 30% of our inpatient units right now are ALC, patients that don't need that level of acuity. So if we can understand what those needs are, we can then work with our community teams through high quality care transitions, get those patients cared for in the community. So I do want to acknowledge right now that we're launching today. Officially. We're still in our infancy, obviously, and we're working through issues around communications. We know that a communication strategy is critical. I think right now there's some angst in the system because we're using different terminology and we're using slightly different language to describe sometimes exactly the same thing in different parts of the province. And so we acknowledge that, and we are working, and over the next several weeks, Jeff Brown from the ministry's communication is assuring me that we're going to have some consistent key messages that we can start to utilize as leaders as we're rolling this out. We'll start to think through the branding of this and what visual representations we want to use when we're describing connected care. We'll think about you know, the language that we're using, et cetera. So there's consistency across all of our teams as we're rolling this out. I'm just going to show you a couple of visuals that we're currently using. They are on your table, so you can take a more in-depth look at them. Again, we really do like this concept of the bridge. We've got the arrows that are indicating that in a high-quality care transition, we're talking about transition into hospital and out of hospital. It's not a one-way bridge. This is a two-way bridge. We've got in the suspension part of the bridge, we've got those 10 domains that we think are critical for teams to be thinking through. We've got 3 levels of enablers that we've talked about here. So we are talking about at the bottom really system level or macro level enablers. We've got organizational level enablers, and then those team enablers in the pillars of the bridge. So you can take some time, look at it, reflect on it, provide feedback to us. This is the time to, if you have input, that it's a good time to give it to us, because we're literally thinking through how we're going to communicate and the visuals we're going to use. The other visual that you've probably seen lots of is this Venn diagram that shows community and hospital care with the patient and family in the center, indicating the transitions of care. We purposefully have made the community bubble larger because we believe that this is really a paradigm shift. So this is about going forward into the future investments. We need to enhance our community-based structure, our community-based services, and sort of shift the thinking away from institutionalized care to community-based services. And again, the concept of the bridge on the bottom. So as I say, we know that there's probably still some confusion. The last thing I would like to leave people with is just thinking about, when we think about connected care teams, I don't want people thinking about that in terms of a noun, okay? A connected care team isn't something new or something different that we're launching into the system. What we're talking about is high-functioning teams anywhere across the continuum of care. The connected piece is about the verb. It's how they're connected internally within the team and how they connect with other teams across the system. So I hope that provides a bit of level setting for today in terms of how we have come from utilizing an evidence-based approach to coming up with a strategy that we think is unique to Saskatchewan, that incorporates best practice from what we've seen around the world, and that we now have a strategy that we would like to see go forward and thinking and acting as one under the new health authority.